today, I will try to answer the question, can we use aminosalicylates in clinical practice in IBD patients? And the answer is very simple. Yes, we can. However, I have next 15 minutes just to prove that. So my lecture consists with few points. First of all, I will focus just shortly on mechanism of action of 5-SA, after about 5-SA in the treatment of ulcerative colitis, and about 5-SA in the treatment of Crohn's disease, especially with focus attention on postoperative Crohn's disease, and few words about chemoprevention with 5-SA. Mechanism of action. We all know that sulfasalazine was originally proposed as a treatment of rheumatoid arthritis in 1950. And subsequently it was discovered that sulfasalazine is also efficacious in the treatment of IBD, especially ulcerative colitis. 5-SA medication were developed because a lot of patients were intolerant or allergic to sulfapyridine, a part of sulfasalazine. And the mechanism of action of this old drug is still unclear. However, they are thought to act topically. And as you can see in this figure, the mechanism of action is inhibition of many of pro-inflammatory mechanisms like cytokine release, arachidonic acid metabolites, and also induction of anti-inflammatory mechanisms like, for example, apoptosis. So finally, 5-SA acts as anti-inflammatory medication, and we all know about that. 5-SA in ulcerative colitis. First of all, proctitis and proctosigmoiditis. In mild and moderate disease, topical 5-SA are recommended for induction of remission and also for maintenance of remission. But for patients unwilling or unable to tolerate any topical medication, and we know that we have such patients, oral 5-SA are recommended, and also oral 5-SA are recommended for patients with multiple relapse on topical therapy. That's also seems to be clear. Left side colitis, extensive colitis, and pancolitis. In patients with mild or moderate disease, combination therapy of oral 5-SA and 5-SA enema or foam is recommended. In maintenance therapy, the same. We recommend oral 5-SA and topical 5-SA. And as we know, we recommend the maintenance therapy with mesalamine for UC patients. However, the compliance is very, very important issue. And as we can see in those figures, we have the percentage of patients staying in remission, and the percentage of patients in remission is pretty stable when we have good compliance. In non-compliance group, the percentage of patients staying in remission is much lower. So we have to ask if the preparation of mesalamine has a role, especially from point of view of the compliance. So the authors of this paper asked the question, are all mesalamine preparations equal? We know from the Podium study that 1 daily dose of granules of mesalamine acts even a little bit better. However, that was not statistically significant, even a little bit better than 2 daily dose. And this is probably because of better compliance with 1 daily dose. And the same study, MOTUS study, was published with induction of remission with 1 daily dose. So when we start thinking about initial mesalamine therapy, we have to personalize the choice of mesalamine preparation. We have to think about minimizing of side effects. We have to think about minimizing cost. We have to think about disease distribution. And we have to personalize selection of formulation. After, if we have failure of intolerance of mesalamine, first we have review patients' adherence, maybe optimal topical therapy for distal colitis, and after there is a need for escalation to corticosteroids, thiopurine, and so on. And of course, we all know that compliance is very, very important issue. And we all know that it's sometimes very difficult to talk about that with our patients. Summarizing that part, oral mesalamine remains a cornerstone of management of mild to moderate ulcerative colitis. Failure of one formulation should not negate future use of entire drug class. Choosing different formulation, we have to take into account economic reason, disease extension, and compliance. In the treatment, 5-SA in the treatment of Crohn's disease, this is a little bit more difficult subject because actually the use of 5-SA in Crohn's disease is still controversial. Meta-analysis from 2011 show us that 5-SA were superior to placebo for induction of remission. However, failure to achieve remission were seen in 68% of patients treated with 5-SA compared with 75% patients treated with placebo. So in order to achieve remission in 1 patient with active Crohn's disease, 11 patients need to be treated. 5-SA from the same meta-analysis, 5-SA plus glucocorticosteroids was not superior to glucocorticosteroids alone for induction of remission, and there was no benefit with 5-SA treatment for maintenance of remission. However, mesalamine and budesonide were similarly effective for treatment of mild to moderate Crohn's disease. So, based on all those data, American College of Gastroenterology, British Society of Gastroenterology both recommended budesonide as a first-line therapy for moderately active Crohn's disease. ECO consensus recommends that 5-SA should not be used in Crohn's disease. However, according to some data and according to some experts, also those from ECO, 5-SA may be an option in some group of patients, especially with colonic Crohn's disease. And some experts argue that 5-SA should be tried in patients with mild Crohn's disease because they are safe, also because of those chemopreventive effects we will discuss a little bit later. Postoperative recurrence of Crohn's disease. Postoperative recurrence could be defined by endoscopic findings and clinical symptoms, and endoscopic findings generally precede clinical symptoms. So therefore, all experts agree that we have to perform endoscopic assessment, usually 6 to 12 months following surgery, to identify patients with a risk of recurrence. Mesalamine prophylaxis is associated with modest benefit in preventing relapse. So this could be an option only for patients who appear to benefit from mesalamine prior to resection, those without high risk of relapse, or those unwilling to consider agents with more side effects like, for example, azathioprine. Chemoprevention, the last part of my lecture. As we can see, cumulative colon cancer risk in IBD patients, especially in ulcerative colitis, seems to be pretty high with time of disease. But not only with time. We have to think that this risk is higher with time of active inflammation. So it's very important to treat active inflammation and to achieve deep remission from point of view of colon cancer. And there is a nice paper by French group, Perrine Biroulet, about 5-SA and chemoprevention. Does it work? And they propose many mechanisms of prevention on molecular basis, like phospholipase D inhibition, COX-2 inhibition, antibacterial properties, anti-TNF-alpha signaling, and so on. But it seems that the most important is just mucosa healing in ulcerative colitis. So, in addition to the anti-inflammatory activity, 5-SA compounds have specific effects on colorectal carcinogenesis at molecular level. A few meta-analyses found a protective association because 5-SA and colorectal cancer in UC patients. However, more recently, some meta-analyses failed to identify the protective effect also in some group of patients. So data are still unclear. However, when we take all those data, it seems that 5-SA therapy may reduce colon cancer risk by healing the mucosa in UC patients and via specific mechanism of action at the molecular level. And according to French group, and I fully agree with that, conducting a clinical trial providing the best level of evidence by comparing UC patients receiving 5-SA treatment versus those in placebo arm would be now unethical. So, I would like to show you our recommendation. They are a recommendation of Polish Society of Gastroenterology published in 2010 concerning treatment with aminosalicylates in ulcerative colitis and also chemopreventive action. And we are recommending 5-SA in the dose of 2 grams per day as a chemoprevention in patients with UC. So, finally, can we use aminosalicylates in clinical practice in IBD patients? Yes, we can, as I said in the beginning. Aminosalicylates are still a cornerstone in the treatment of mild and moderate UC. The role of 5-SA in Crohn's disease is unclear. However, in some patients, in some group of patients, especially with colonic Crohn's disease, we can still use it. And there is a place for mesalamine in relapse prevention after surgery, of course only in specific group of patients. And mesalamine therapy, but not sulfasalazine therapy, may reduce colon cancer risk by healing the mucosa in UC patients and maybe in colonic Crohn. So, finally, I would like to say about mesalamine, like about your beautiful statue in Petersburg, old but gold. Thank you very much.